A lot of my time working on programs that are poorly implemented. Sometimes they're poorly implemented and sometimes they're poorly designed. This is an example of the latter. Most of the time they don't have an effect. This time the program actually had a big effect. And so the question is, how did it happen? So let me go on and talk about it. Background was just again in terms of resource constraints, low maternal and child health, particularly in regions such as Bihar. One primary reason for that, or one reason that is most frequently cited for that, is the low quality of Anganwadi centers, which are the frontline institution as far in the ICDS. And of course, there are lots of theories of economic growth which talk about that. The low quality is really the low quality of the people who are working there. So that's one of the things that has been emphasized. And if you have low human capital, that's going to cause all this intergenerational persistence. Okay, it's actually been difficult to test empirically, and what I'm thinking of testing empirically is human capital a constraint on health? So is the quality of Anganwadi workers, is that a constraint on health? It's been difficult to test because our policies are decentralized, and so the Anganwadi worker is recruited from the village, which means her level of education reflects the level of education of the village, so you have this huge simultaneity problem. The other reason it's difficult to test is because there's little variation in schooling because you have these educational criteria. So if you are an Anganwadi worker, you have to have 8 years of education, which means all Anganwadi workers have 8 years of education. And so you can't do anything empirical because there's no variation in education level. You also have an additional problem. There's been some work that's been done in schooling. So this is work that, for example, looks at the implications of putting in somebody of less education, a contract worker. The challenge over here is that if you put in a person, you're doing two things simultaneously. You're affecting levels of education, but you're also affecting the number of workers. And so there are two constraints that are being addressed. One is the human capital constraint, and the other is the labor constraint. And you need to separate out those two effects, and that's been very difficult to do. So that's exactly what I'm going to do over here. I'm going to separate out the labor constraint and the human capital constraint and talk about which one of them was really binding. I'm going to do this in the context of a pilot program in Bihar. It's called the Uddeepan program. The Uddeepan program was designed specifically with the hypothesis that the real constraint on the quality of Anganwadi centers is the education of the workers, the Anganwadi workers. And so it was a program designed to address the human capital constraint. What did it do? It hired one person from the GP, from the Gram Panchayat, the Uddipika. Uddipika had to have 12 plus years of schooling. So this is a substantial change in levels of education from 8 to 12 plus. It was a targeted program. They were told to focus on children less than 3 years of age, as well as pregnant and lactating women. And so the impact was going to be seen primarily on that. And that was through what they were told to emphasize: breastfeeding, nutrition, all the other things that go along with that. Okay, so as I said, the contribution of this paper is in separately identifying human capital and labor constraints. The effect on human capital constraint is just measured as the difference in education between the Uddipika and other people in the GP. I'm able to do that because there was an entrance exam test for Uddipikas. So I actually have the test score, and that gives me a much better measure of education than 12 plus years of education, 8 plus years of education. The reason I'm able to separate out the human capital constraint from the labor constraint is that the people who implemented the policy didn't think that they were solving a labor constraint policy as well. And so the way they implemented the program actually resulted in variation in the extent that the program addressed this labor constraint across GPs. And so there's very nice variation in that, which is what I exploit for the paper. There's a related literature. Most of the literature which has looked at the quality of either schools or on healthcare institutions has looked at questions of access. Then they've looked at questions like student-teacher ratios or the number of beds, etc., those sort of population measures, but haven't really gone beyond that to looking at concrete measures of labor availability and human capital availability. Okay, so just to preview my results, I'm going to find, I do find a significant effect of the program on child weight for age Z-scores. I find that the programs primarily, the reason it worked was primarily because it reduced the labor constraint and not because it had anything on the human capital constraint. So this suggests actually, contrary to what a lot of people think, that the labor constraint is the binding constraint, at least in this part of Bihar. I find a large effect of the program, and then I go into reasons why this effect was large. Again, completely by accident. In fact, when I presented this report to DFID, who funded it, they were the first to say, oh, this was completely unintended. We had no idea that the policy was designed in such a way as to have this effect. As it turned out, the policy was designed in such a way that it had a massive effect. So here's a good outcome, but again, what's upsetting about it is it was completely unintended and was not part of the policy at all. Okay, Anganwadi centers, there was a Supreme Court order universalizing them. So there was this massive increase in the number of Anganwadi centers, and I've given some of the data over there. When you have this massive increase in the number of centers, you have to staff them. And so there was this resource constraint and a human capital constraint. The labor constraint comes out in the bottom two figures. So if you look at the number of Anganwadi centers per children, in India it's 70. In Bihar, the number of children per Anganwadi center is 175. So again, even with this increase, you know that they were doing badly. So that's the indication of the labor constraint. These are, I don't know if you can see them very well, but these are indications of the human capital constraint. So Anganwadi centers are required to keep registers. And this is actually a register which just records the age of the children. So you can look at these two. This is Vimla Devi and Suchitra Devi, and she's 3 months old and 5 months old. And in the next month, because this is recorded every month, in the next month she becomes 22 years and 2 months old, and 23 years and 4 months old, literally from May to June. So you ask them, how did this happen? And do you know what you're writing down? And this is not one register. This happens throughout. It's much more, it's terrible when it comes to actually recording weight. So the reason that this is so shocking is that this is recording age. And they just say that, we don't know what we're doing. We don't have the training. So I said, did you know you were recording age? And she said, no. Somebody else came in and recorded it. But that's the level in which there's a human capital constraint, and that the registers of the information that's being collected is just not there. This is, of course, a standard one, that they're all supposed to take weight. And so they actually have been given weighing machines. They're never there, so you ask them, do you have one? And yes, they do have one. And it's carefully packed away, and so you have to take it out and open up the plastic. And then you ask them, well, why aren't you using it? And then the stock response, this sometimes seems shocking. The stock response is, we don't know how to record it. So I said, the child has to stand there. They don't know how to record it, is basically what it comes down to. So again, to anyone who sees this, it seems that there's a human capital constraint, and it's a very, very big one. Okay, so the program, as I said, was a Government of Bihar and DFID program. It was part of a larger program to intervene in health. But the Uddeepan program was the one that was focused on strengthening Anganwadi centers. It went through phases. So there was a phase one, which was the most backward districts, based on an index that was constructed. This is also, I think, because now programs are always told you must have an evaluation component built in. So when I arrived to evaluate it, the people who were implementing on the ground were very pleased, because they kept saying, don't worry, we have an evaluation district. It's been kept aside for evaluation purposes, and it was randomly selected. So you can do a randomization. And I try to tell them that if I have one district that's randomly selected, I can't really use it for a RCT or anything, but they kept insisting that I should be able to do a really good study because they had this control district. There were also phase two districts, which were never part of the program for the period that I was doing. So I actually do have some sort of set of controls. Program started in 2014, and it closed in May 2016. As I said, the initial problem was as a resource constraint, and the program was supposed to address the resource constraint. And so the approach was a different approach. It was a cluster approach. And this was actually quite a novel experiment that everybody was very interested in. How did it work? Well, Anganwadi centers in any case have a cluster approach, but that cluster approach is at the level of the block. This cluster approach under Uddeepan was at the level of a gram panchayat. So a gram panchayat typically has about 7 or 8 Anganwadi centers. And because they were trying to address the human capital constraint, they put this Uddeepika with more education at the level of a gram panchayat. And so she was supposed to then distribute her time around the Anganwadi centers, go and talk to all of them, she had a requirement that she circulate around all the Anganwadi centers. So she spends about 2 days a month in each of the Anganwadi centers, hand-holding support, et cetera, et cetera. But she was supposed to be the one who's sort of transmitting human capital to all of them. So it's a clustered approach. That was the idea of how are we going to address this human capital constraint, instead of making a requirement, which other states have done, that all Anganwadi workers have to be a certain level of education. I think it's actually a fairly brilliant insight that we just have to give one educated person to a cluster and then let education work, because that's supposed to be a public good and it's going to spill over to everything else. The Uddeepika is selected from within the Gram Panchayat. She is 12 plus, supposed to have 12 plus years of education, and she's supposed to get more than 60% in an entrance exam test, which is basically a test of general education. And that is what goes on with the test. We ran a survey on this. So the survey covers districts in the northeast of Bihar. It's a fairly large sample, about 4,500 households, a baseline and an end line. But basically, we were called in very late into this. We thought the end line was going to be after a year and a half to 2 years. But then they announced that they're closing the program, so we better hurry up and do our end line survey. And so the period between the baseline and the end line is compressed. It's about a 9-month period between them. Okay, so the standard way you would think of evaluating this is a difference in difference. You can compare baseline and end lines. The problem is that you have a very compressed period, so you're only going to get effects after a 9-month period, and that's going to be after the program has started. So you would expect the diff effects might be quite small. The main problem with the program, however, was, so with the program, not with the evaluation, is implementation was very weak. So if you look at the data, they were supposed to have started in 2014, but in the districts by the end of 2014, the numbers, the percentage of the Uddeepikas that had been put in place was only about 30% and 40%. So just as if I was in my teaching mode, I would throw this out as a question: why do you think that there weren't Uddeepikas put in place? The answer is that they've gone to a state, which is Bihar. The problem in Bihar is there's very low levels of human capital. And that's why Anganwadi workers are generally of low levels of education. And they've decided that we're going to address this. But how are they going to address this? They're going to take Anganwadi workers from the Gram Panchayat itself. So if the problem is there's no educated people, you're not going to be able to hire Uddeepikas because there are no educated people. And that was something I think that escaped them, that the problem that they had sent out to solve meant that they could not take a decentralized solution to that. If there is no educated person, you're not going to be able to hire anyone who's educated. And that's exactly what happened. They just didn't have enough eligible candidates, so they had no one to interview. This is data from Madhepura. The red line is a 60% score. These are people who were deemed, got everything else but the entrance exam score. And you can just see that they literally did not have enough people for the implementation. Okay, so the program was phased in 2 ways. One was the phasing that I talked about, phase 1 districts and phase 2 districts and super. But then it turned out there was this endogenous phasing almost, that there's a lot of variation across Gram Panchayats in the duration of the program. Some of the Gram Panchayats had the program running for 2 years, and others had it running just for a few months. And this is a histogram of the duration exposure for round 1 and round 2. But there's a tremendous amount of variation across Gram Panchayats. Okay, so as far as the evaluation goes, this suggests a different strategy. Instead of using a time series variation in a different approach, you use a cross-sectional variation. And the cross-sectional then is going to compare across GPs at any point of time. That's obviously endogenous, but you're going to take care of it with this targeting to households. So the difference in difference on a cross-sectional level is a difference between, say, high-intensity Gram Panchayats and low-intensity Gram Panchayats, with intensity defined by months of exposure, and then relying on the fact that it's targeted to children below 3. Okay, so this is the data I'm going to show you is the very simple illustration of that diff method. And you can see from that for children who are 5 to 6, the trends are similar, and then it just increases. And so just from this figure alone, you can see that there's an impact of the program on younger children. This is not a great, so the simple implementation of this cross-sectional diff, is not a great thing to go with, and the main problem happens to be with the age of children. Okay, what matters here, the child was targeted if the child was less than 3 at the time the program starts. So it's not just a pure age effect, it's an age times a GP effect. It's a cutoff that varies across ages and GPs. And so it's difficult to compare, to devise this age control in the control GPs. In the control GP, the program was never implemented. So what I've done over here is just take it by different ages, but it's hard to get a pure diff just with the way the program was implemented. So what I work with then is a continuous measure of exposure to the program. So we use, because we are working with the government in getting this, we actually got very, very detailed implementation data. So we know exactly the month in which the program started in the Gram Panchayat. And so with that, we can actually construct months of exposure in the duration of exposure in months. So that varies across GPs and across rounds, and we interact that with age effects. But basically, the exposure is if you are born before the program started, then exposure is the duration that the program was running in the GP. If you are born after the program started, then the duration is your age in months. Okay, so that gives you this exposure variable, which is actually an interaction between gram panchayat and age. And that's essentially what allows me to identify it. It's run as a different diff in that there are GP fixed effects, round fixed effects, age fixed effects, and then it's an interaction between GP and age, which is really what's determining exposure. Okay, as a robustness check, I use an IV method. Okay, so I have a different diff that's just an OLS with fixed effects essentially. But then we have the fact that the implementation of the program really depended on the number of eligible candidates. And I actually had the test scores. I had all the people who applied. I had the test scores of all the people who made it through the first cut. And I had a second set of test scores, which is the 12th standard examination scores of a much wider pool of applicants. So this means I can take the duration of exposure of the program in the gram panchayat and instrument it with the number of eligible candidates who were there in the village. And that's a stronger thing. I don't have such a large sample size for that, so I'm going to report a Hausman test based on an IV, comparing it to the others, and then just go with that. Okay, so how do you decompose it into human capital and labor constraints? The first line is just the population per worker constraint. And the constraint is going to come in as the difference between the population per worker under the old regime, under the old policy, and then the population per worker ratios under the new policy. And a similar thing for education. So then it just comes down to measuring the population per worker under the new regime. Okay, and this is what gives it. And where do I get this variation? The variation comes from the variation in the number of Anganwadi centers in a GP. Okay, so that number varies quite tremendously. So it turns out that one Uddeepika is assigned per GP. In some GPs, she only has 4 Anganwadi centers to take care of. In other GPs, she has 15 Anganwadi centers to take care of. And so the extent to which you're relieving the labor constraint varies across GPs, depending on the number of Anganwadi centers per GP. And so that's the way I identify the labor constraint. The human capital constraint is identified by using test scores. So I use the test score of the Uddeepika compared to the average test score of the pool of applicants, assuming that the test score of the pool of applicants, because they're all from the same gram panchayat, is a measure of ability in the gram panchayat. I do a robustness check with a second test score, which is a 12th standard exam. So again, it's the exam results for the Uddeepika compared to the exam results of the whole pool of applicants from the gram panchayat. This is just showing you the correlation between the 12th standard exam scores and the results on the entrance exam tests. Okay, so the first set of results is just showing you that it has an effect. The first is a simple diff and diff, which is relying more on the time series variation. The second is putting in the continuous measure of exposure with the gram panchayat fixed effect. And the numbers are very similar. The different diff is based on 7 months of exposure. So it translates into 0.07 standard deviations per month. And that's very similar to the 0.02 that I get otherwise. So the program worked, despite the fact that it was implemented really poorly, and despite the fact that we know that the education level of all the Uddeepikas was low. This cutoff score was 60%. And then when they couldn't find enough people of 60%, they actually reduced the score to 45%. And if you were from a scheduled caste or scheduled tribe, the score was reduced further to 40%. So when they actually implemented the program, they were not addressing the human capital constraint at all. They basically gave up on that and said, we're going to put in another worker, because this ability thing had fallen from 60% to 45 to 40%. Okay, so even with that, they didn't have an educated worker. The program had an effect. Okay, so this is the effect of the program. The first one is if there was no exposure. The second is the middle one is exposure after 13 months, which was the average program duration, and then 24 months. So you can see that the effect on rates for age is actually quite high. When you decompose it into this labor return and then the effect on ability difference, they're both significant, but the labor effect is much larger than the effect through the ability difference. And so it's telling you that the program worked primarily because it reduced the labor constraints in an Anganwadi center, not because it reduced the human capital constraints. Okay, so this is just a graph to illustrate this. So the population per worker difference is just telling you how much the program affected the population per worker. It had a massive difference in terms of labor constraint in GPs in which there were very few Anganwadi centers, which is exactly what I was telling you. If she only has to deal with 4 Anganwadi centers, there's going to be a massive effect on that labor constraint. And so there was this difference in the labor constraint. This is the ability difference. And you can see that the ability difference doesn't vary much with Anganwadi centers, but generally it's low. So the extent to which the program affected the ability difference was small. The extent to which it affected this labor constraint was large, particularly in GPs in which there were very few Anganwadi centers. Okay, so this is another graph which helps you understand the results. The first one here is, this is just predicted weight with the full model. This is predicted weight when if there was no program at all. Okay, so the difference is telling you that the program was effective, and the difference again is largest when there are very few Anganwadi centers per GP. I can now do predictions because this is a structural model estimations. I can show you all the prediction results. What if I shut off the labor constraint and say the program had no effect on labor constraints, so put that equal to 0, allow the program only to affect the ability difference? This is what the result would have been. Okay, so the effectiveness of the program would just be this difference, and the program would not have been that effective. If I do the opposite, and I shut off the ability difference and say the program had no effect on ability differences, or set that equal to 0, and only allow the program to work through the labor constraint, that's what the effect would be. And that's very close to the full effect. So graphically, that's just a way of showing that the way the program worked was really because it affected this labor constraint, not because it had any effect on the human capital constraint. These are other ways of just showing the same thing. This is, on the top is just the population per worker difference. And so where the population per worker difference was the most, that's where you had the greatest improvement in weight. Weight was on the Z-scores. And where the population per difference was the smallest, you had very little movement in that. So again, it was the labor constraint that was driving the difference. The obvious question to ask then is, well, there was very little change in education. So maybe the low effects of the human capital constraint was just because we never budged that human capital constraint that much. We hired people of low levels of education, and that's why it wasn't effective. You can do simulations based on the result, and what the simulations show is that even if they had met that 65% score, the effect would have been only marginal. Basically, what the results are saying is that the return to an educated worker, even if you had taken a worker with a higher level of education, the return to an educated worker is low. Okay, this is a surprise, because I think a lot of people would think that if you go into rural schools and Anganwadi centers and all the frontline institutions, the problem is a human capital constraint, and that if we were able to put more educated workers into these institutions, we would have a big difference in results. And this is actually saying, no, the problem is not a problem of human capital. The problem is just a problem of labor, and that's what you should focus on. So as I said in the beginning, this is an example of a program that had a large effect, even though the premise of the program was wrong, but it did because it affected another constraint which they weren't aware of, and they did that. Why does education have so little of an effect? We looked at mother's knowledge. Mother's knowledge is low in a variety of different ways. But the program didn't move that at all. Okay, so if you look at duration of breastfeeding, do you know DPT dosage, et cetera, there was almost no difference in that, and they weren't able to move that. And this is just regressions which show you that the program, in fact, did not budge mother's knowledge of these topics. It had no impact on that. Several explanations. This paper does not test those explanations, but some of them may be due to poor physical capital. Okay, so I did show you the weighing scales, etc., but in many other parts, Anganwadi centers, they don't have that physical capital, and so they aren't able to use their education in some sense. They aren't able to set up a nutrition surveillance thing, but that's just speculative now. Why are the effects so large? So I said again that this was something that was unintended. It turns out that GPs in which there are very few Anganwadi centers, or the number of Anganwadi centers per GP, is correlated with the extent of the labor constraint. This is again population per Anganwadi center. So the program had this huge effect. What it did, again unintended, was the most labor constrained Anganwadi centers, that's where the project had the greatest return. And that's what makes the effect so large, because it actually directed resources to the most labor constrained GPs. This is a control essentially. So normally as the constraints, the labor constraint in a GP grows, you'll see weight for age Z scores are falling off. We see the opposite in the treatment places. How did it happen? Number of Anganwadi centers in a GP increases with GP population. That normally means that those with the fewest Anganwadi centers are the least constrained. And that happens just because of this population rule. But the number of Anganwadi centers in a GP is also determined not purely on a population rule, but also on the basis of residents, number of hamlets in a village. And that has the opposite effect. So those are the fewest Anganwadi centers are the most constrained because of this particular rule. So you have two factors going in opposite directions. This one actually dominates, and a result of this was the policy. So these are just value-added regressions showing you the two correlations I showed you earlier. And this is basically telling you that what I've been just saying, that where you have the smallest number of Anganwadi centers in a GP, that's where the population constraints are the most. So more resources were given to GPs with the fewest Anganwadi centers. It turns out, again, just because of the way Anganwadi centers are allocated, that those are the GPs that were the most labor constrained. So the program that was intended to be a human capital program ended up being a labor constraint program. Not only was it one that affected labor constraints, but it also did it in this beautiful way that it gave more labor to the most constrained GPs, as a result of which it ended up having a huge effect. Both these, the fact that it addressed the labor constraint and the fact that it actually addressed the labor constraint the most in the GPs that needed it the most, both of those were unintended and not part of the program at all. So the program worked beautifully for no reason of the design of the program. The bottom lines and the conclusions from this is that improving the quality of Anganwadi centers, so that's what they actually did do, did have a very large effect on health. But the reason it is going down to the bottom, it was more of again, not by design, it ended up being a targeted program that gave more resources to the most constrained GPs, and that is the reason it had such a large effect. On the education side, I come away, and I think this was echoed in some of the earlier talks, decentralized policies are unlikely to reduce a human capital constraint. So you went to Bihar, know that there's a problem that there aren't educated workers in Bihar, and you put in place a policy which said that the worker has to be recruited from the local area. Okay, that's putting in a policy that's just not going to work as far as the human capital constraint is. So if we are going to address these, again, I think this goes back to the morning talks. If there is a human capital constraint, it's going to have to be through policies that are not decentralized. But in the current context, that improvement in education would not have helped.